Dr. Adrian used to tell me, the proof of the pudding is in the eating. So if the patient is not happy, all of this is going to fail. I have tried to keep my talk as less mathematical as possible, and it's really simple. It's not an advertisement for any calculator. It's not a theory that we are formulating. I'm just going to share with you what we have done for our patients and our results. And you are free to have different opinions, or you are free to ask me any questions as and when you feel like. So we have no financial disclosure. People ask everyone, why did you become a doctor? Some say, do good. Some say for the respect. I simply became because I hate maths. And Vidham already took the thunder out of that slide earlier, but anyways. So earlier, or even now, post-refractive surgery, cataract surgeries would mean one equation and another and another and another. It would leave me looking something like this. About 2 to 3 years back, we discovered the ACRS calculator and actually how simple it was. At the onset, again, this is not an advertisement for this calculator. In fact, when you go online and you click on it, there is a disclaimer that everyone has to accept. The calculator, as well as me, we don't hold any responsibility for any errors you get, but we do use it and we are very happy using it. Okay, so let's begin one by one. These are a lot of boxes, a lot of big names or big machines which most of us or most of the people who are practicing by themselves don't have and never even heard of. What does the calculator include? So it has the patient data, as any calculator would. Then this is the pre-LASIK data. Few patients who got the LASIK done at good centers might have this data with them, but let us just assume that the worst case, most of the patients we're going to be getting will have no such data. Now this second slot is for the post-LASIK data. Majority of the slots are actually a delta value, which means that you take the pre-op values and you minus the post-op values, which come in the spherical error section and the K section. Now the topographic data that we use is actually the rings of 0, 1, 2 and 3 millimeters. The calculator wants the atlas values. Atlas is a placido-based topographer, so it just gives you the anterior corneal values. We have discovered during our experience that a pentacam, for those who have access to pentacam, gives a better value for these central rings, because the pentacam takes the anterior as well as the posterior curvature in account. So that ratio shift, which is happening post-LASIK surgery, is already accounted for in the pentacam, and we believe that the pentacam has better values for these rings. The effective refractive power, if you don't have an ISIS system, we again use a pentacam for this. Pentacam has something called the EKR report by Holiday, which I will be showing later. There is a slot which says the 65% mean K value. Now there was a talk by Dr. Bellin in ASIS a couple of years earlier. They showed that the effective refractive power matched very closely to the 65% mean. So we use that as a substitute. Again, the Galilei has something called the total corneal power, and there is published literature, I think Vidima cited it in her paper also, which says that the central or the total axial map of the op scan matches very closely with the total corneal power. So using these instruments, we try to work out the best formulas for our patients. How we do it, I'm going to explain in a stepwise manner now. This of course is the normal biometric values for your data using either the IOL master or the LENSTAR, or even the normal A-scan instruments that you have. This is an important part because the different instruments that we use, we have multiple centers. One of our centers we use the IOL master, which has a different keratometric index. The keratometric index for the IOL master is 1.332, and the keratometric index for something like a LENSTAR by height stray, which we have in another center, has an index value of 1.3375. And although it looks like a very small deviation, it affects the lens power calculation substantially. So you have to be sure of what KI is for your instrument and correct it accordingly. Then you just go and calculate and you get all of these formulas. Karishma has already explained to you. The first set of formulas is when you have all the pre-operative data. The second set of formula is when you have the pre and post and you have the delta values. And the C is without any pre-operative data. Although I'm not very good at maths, like I already said, I do understand a little bit. The more number of values you have, the better is going to be the average for that set of values. Now, what is different between between ACRS calculator and other individual formulas is that it engages multiple formulas. So So at the end of a calculation, you have multiple values for the IOL power, and hence the average is more accurate and more precise. So the more data you have in these three zones, the more number of formulas the calculator will be able to engage, and the more number of values will have to come out with an average, and hence your average would be as close to precise as possible. Moving on. So why I'm taking this is the first case which I'll be discussing. This was a very interesting case. We have 3 centers in Bangalore and we do post-LASIK cataracts everywhere. This gentleman came to us in one center, a particular center, and he had got LASIK done about 10 years back. He had developed an NS3 to 4 cataract, young man, and he got worked up in the first center. What happened after that is we lost him to follow-up, and then he suddenly appeared in the other center, got worked up there independently of the 2 centers, and got the lens implanted with good results. So this was his vision. Before we go, one thing I wanted to again clarify. See, all the patients who are going to come to you post-LASIK cataract surgery, the slots that we have for post-op refraction is not always reliable. Because pre-op refraction would be stable, the patient would have reports for that. Post-op refraction, till what time it was stable, you might not know. Because if the cataract has been developing for 3 or 4 years, he will start getting lenticular myopia. So by the time this patient came to us, he had -15 diopter of myopia, which is obviously lenticular. You can't use these values in your post-op refraction. So you have to be very wary, and you have to be absolutely sure that the values they are giving your post-op refraction are stable. And this was his vision. So, like I said, it was 2 different centers where he was worked up differently. In the first center, we used the IOL master and the op scan to work up the patient. In the second center, we have the pentacam and the LENSTAR. But regardless of what instruments we use, we always apply the data to the ASCRS calculator. If I have just my center value and I have my paracentral values, I will still be able to make a decent enough calculation to have patient who's happy. Now, I'm not disputing that you don't need a topographer or topographer is not required. Of course, in ophthalmology there are 2 schools of thought. One, people will split hair and say that it has to be accurate to 0.00 emetropia. There's another school of thought that says 0.5 or 0.1 diopter myopia, patient is still happy. So it depends on which school of thought you belong to. And I'm trying to make this talk easier or to understand, make those people understand who probably don't have access to a topographer, who are staying in a place like PVP and who don't have an op scan or a pentacam. What do they do? So yeah, so this is the center one. Coming back, this is the A scan value. This is the value which we use from the op scan. Now we put these values in the ASCRS calculator. The A scan values go here. The op scan value, as already discussed, goes in the TCP. And again, we did change the keratometric index to match the data that we had entered in the formula in the calculator, and it gave us these 4 sets of values. We went for the average value. So it was planned to put a 19 diopter lens in this patient. However, this patient was lost to follow-up. Then he appeared in the second center where we have the Hart's-Fryer LENSTAR for IOL bar calculation or A scan. And this is his A scan in the center too. Now this is interesting. For those who have the pentacam or who have access to a pentacam, pentacam is a very interesting machine and it's actually pretty accurate in most of the things it does. We use multiple values from the pentacam. So first, we use the mean zonal EKR values, which gives you the EKR. EKR is actually the effective K power reading for the 1 millimeter zone, 2 millimeter zone, 3 and 4, which is already been shown by Dr. Karishma. Then it gives you something known as 65% mean EKR, and it has been proved by a group led by Dr. Bellin in US that this matches pretty close to the effective refractive path. And then you have a EKR map which gives you the path right at the center. So now what all do I have? I have my 1, 2 and 3 millimeter from the mean zonal EKR. I have my central corneal path from the center EKR map, and I have my effective refractive path. So again, I have my A scan from the LENSTAR. Please note that the keratometric index here has been changed. You need to go to the settings of the machine and find out what the keratometric index is and adjust it accordingly. Then you calculate, and this is what we got. One thing off the topic, we generally use the IQ in such patients, and again, the literature shows that the IQ has a slight anterior shift post-operatively. So the ELP, which the formula calculates, you always have a little hyperopic shift. So Normal tendency is to overcorrect the patient by 0.25 to 5, but for the IQ, what we do is we just undercorrect it. We take the first plus value because it shifts anteriorly. Otherwise, the patient is left with a little bit of myopia. So what we chose was 19.5 in this patient. He was implanted with 19.5 diopter lenses, and this was his refraction post-op. So even if we had put 19 diopter, he would probably have been E-metro. Still a very acceptable result. Just as an afterthought, if we had simply gone with the SRKT formula in the IOL Master and LENSTAR, the power we would have been implanting a 16 or a 15.5 diopter lens. So we would have been undercorrecting the patient by 3 diopters, and you would have needed 6 diopters of power for actual reading. So you can just imagine how unhappy the patient would have been. So a point here is that the flatter the cornea, the bigger this difference is going to be. Because the ratio of a normal to an abnormal cornea increases with the amount of correction. So I have another patient, the case I'm going to show. Her cornea was in the early 40s. This patient's cornea was in the mid 30s. So her normal A-scan value and the calculated A-scan value through the ASCRS calculator differed by about a diopter. But because this person had more flat corneas, there was quite a big difference. Anyways, moving on. Now, this was something which came to my mind retrospectively because this patient had 2 different sets of calculation and we reached the same formula. Then I read up about the ASCRS calculator and I realized that the formulas that the ASCRS calculator engages are not the normal regression formulas that we use for a normal patient. They are formulas which use autocorrected K. They have their own equations like Sharma's subtract 6.8, etc., etc. So they have their own inbuilt corrections for the K value they use in this formula. So what the Sharma's formula, the Hagee's formula does is, if you don't have any pre-op K, it uses the K value of the normal population. The normative K value is about 43.86, and it might subtract the K value that you put in from your IOL Master or your LENSTAR or your keratometry. So the K value that the Sharma is using is already corrected for post-LASIK corneal curvature. And the K value that an SRKT uses is not corrected. That is where essentially the problem lies. So I said, let's see if someone wants to, just try it out. I stay in a, very awkward place, in a small place, no topographer. What if I did not have an op scan in the first center and I did not have a pentacam in the other center? So I went back to the calculator, I fed the details of the A-scan only in the IOL Master, corrected for the keratometric index, no topographic data, no total corneal power, and I pressed calculate. This is what I got. I got a 19.03 diopters. So again, I would have anyways ended up putting a 19 diopter. Then I went to the LENSTAR, I put the A-scan, and no topographic data, correct for the keratometric index, calculate, 19.3. I would have again either implanted a 19 or a 19.5. So one thing I am saying here, very important what I am trying to say is, I am not disapproving or I am not saying that the topographers are not needed. I am talking worst case scenario. If you have a patient and you don't have access to topographer, no need to lose heart. Even if you use a calculator with the minimum basic data, you will not be off by more. And always, if you want to be sure, like Dr. Ridhima said, overcorrect. If you overcorrect, the patient will never be unhappy. Now quickly I'm going to run through this. This is the second case. Here, what is difference is we had pre and post-op stable refraction after LASIK. And we use the same data, we use the op scan, the IOL Master, and this patient had astigmatism, so we wanted to put a toric in this patient. Again, this is the A scan from the IOL Master, the total axial power from the op scan. Here, apart from all the regular entries, we had the pre and post-op refraction also. We calculate, we got a value of 9.4, we decided to put a 9.5 diopter lens, but this patient had astigmatism as well. So if a patient post-op has astigmatism and you want to put it to a toric, it's just as similar as a normal patient whom you're planning a toric. Just use the spherical power, enter it in your toric calculator, and you'll get the value. One thing you have to keep in mind, if the ablation is too decentered, the astigmatism is too irregular, then it's better to avoid a toric. But this patient had a regular astigmatism and the ablation was reasonably uniform. And this was the post-op vision and refraction. Again, what if we didn't have op scan? So this is just the refraction and the IOL Master. Again, the keratometric index, no op scan data, 9.3. You would have still implanted 9.5 diopters. So these are results with 23 eyes that we've done using the ASIS calculator. And you can see, apart from 2 patients, one had a hyperopia of 1.25, one had a hyperopia of 0.75. Our average has been slight myopia of 0.38 with a standard deviation of plus minus 0.65. And 21 of those have landed within plus 0.5 and minus 1 diopter, which is acceptable in any platform with post-op LASIK cataract. So key takeaway, regardless of the method employed for biometry, we believe that the ESCRS calculator gives more precise and acceptable. Acceptable, I think, is the key word here. I cannot say it's going to be bullseye and bang on, but it's more acceptable for the patient as well as for the doctor. In post-practice surgery calculation, these are my references, and thank you.